Hi everyone, and welcome to today's session on ectopic pregnancies. My name is Ashlina, and we have Tyreen, Reese, and Jade here with us today. Firstly, what is an ectopic pregnancy? It is an extrauterine pregnancy where a fertilized ovum implants in an abnormal location, other than the endometrial lining in women of reproductive age. This environment is not suitable for the embryo to thrive and develop, and if left untreated, can cause life-threatening issues for the patient. Ectopic pregnancies account for 2% of all pregnancies, and up to 14% result in mortality. Early detection can prevent severe medical complications, decrease mortality rates, preserve fertility, and permanent damage of the fallopian tubes. Query for an ectopic pregnancy is considered a medical emergency, and patients must be seen as soon as possible by the sonographer. Normally, the fallopian tube will carry the fertilized ovum into the uterus. However, if there's any damage or obstruction to the fallopian tube, it can impair the normal function. This is a predisposing factor for ectopic gestation, as it impairs migration of the fertilized egg to enter the uterus. Tubular motility can also be impaired if the tubal wall doesn't contract and propagate the ovum through the fallopian tube. Alterations in the tubal microenvironment will also stimulate and allow for early implantation to occur. In some cases, ectopic pregnancies can be idiopathic. However, there has been a significant association with ectopic pregnancies and the use of an intrauterine contraception device, prior abdominal, pelvic, or tubal surgery, and a history of previous ectopic pregnancies. Moderate risk factors include tubal pathology, more than one sexual partner, smoking, assisted reproductive technology, endometriosis, increased maternal age, and current or prior ascending infections such as PID, chlamydia, and gonorrhea. 50% of all ectopic pregnancies are asymptomatic, and if symptoms occur, it's usually between the 4th and 10th week of pregnancy. Ectopic pregnancy is a major diagnostic consideration of women in reproductive age who are pregnant and complain of pelvic pain, usually unilateral, and abnormal vaginal bleeding or discharge. Common pregnancy symptoms such as diarrhea, dizziness, vomiting can also be experienced.
The maternal mortality rate of ectopic pregnancies has significantly decreased from 72 to 90% in 1880 to 0.14% in 1990. Ectopic pregnancy, however, remains the leading cause of maternal death in the first trimester of pregnancy. Early and accurate diagnosis is and has been crucial in the reduction of mortality rates associated with the complications of an ectopic pregnancy. Ultrasonography is an ideal method of early detection by a trained physician and is performed when there is suspicion of an ectopic pregnancy. Ultrasound is ideal as it is accurate, portable, and provides a rapid diagnosis of conditions which are associated with complications in the first trimester, including ectopic pregnancies. At the initial ultrasound examination, approximately 90% of ectopic pregnancies are located. Any ectopic pregnancies that are not detected are known as pregnancy of unknown location. The detection of an ectopic pregnancy is highly dependent on the skill level and quality of the ultrasound scan. The majority of ultrasound facilities that utilize modern transvaginal protocols are adequate in diagnosing an ectopic pregnancy in the first examination, which reduces the risk of being diagnosed with a PUL. The use of pelvic ultrasonography has transformed investigations within obstetric environments. Ultrasound allows direct visualization of gestational events within the first trimester, which allows for the detection of ectopic and non-viable pregnancies. A transabdominal approach provides an overall view of the pelvic and abdominal structures, while a transvaginal approach allows for increased resolution and a more focused view of gynecological structures. Both methods are usually performed in clinical practice to determine an ectopic pregnancy. However, studies show that the transvaginal approach is superior to a transabdominal approach in the early diagnosis. Transvaginal imaging is superior to transabdominal due to a higher resolution from higher frequency probes being closer to the gynecological structures that are being evaluated. The transvaginal approach also provides more accurate data in obese patients and can be performed when the patient's bladder is empty. Informed consent is required when any form of ultrasound is performed. However, as transvaginal approach is quite invasive, written consent is usually required.
In general, ectopic pregnancies or EPs can be classed as tubal or non-tubal, with tubal EPs making up around 95% of cases. Non-tubal varieties are found in the uterine interstitium, cervix, ovary, and previous cesarean section scars. Tubal EPs are most commonly found in the ampulla in 70 to 80% of cases. Normal fallopian tubes are not usually seen in ultrasound. However, pathological changes such as EPs distend the tubes, making them easier to visualize. The corpus luteum, observed as a ring of fire on color Doppler, is a useful marker and will be present on the ipsilateral side in 70 to 85% of tubal EPs. 60% of EPs are seen as an inhomogeneous mass adjacent to the ovary, known as the blob sign, and 20% manifest as a hyperechoic ring surrounding an empty gestational sac, known as the bagel sign. Investigation of potential EPs should include an inspection of the pouch of Douglas. If free fluid in the pouch of Douglas has low-level internal echoes or a ground glass semblance, it suggests a hemorrhage. This can be a consequence of tubal EP rupture, although it can also be indicative of blood leaking from the fimbrial end of the fallopian tube. Interstitial pregnancy is rare, but extremely dangerous due to the high vascularity supplied by both the ovarian and uterine arteries, and the fact that gestation may advance to the 16th week. Trophoblastic tissue is found outside the endometrial cavity where the fallopian tubes dissect the myometrium. Consequently, a thin layer of myometrium surrounds the interstitial pregnancy. The sonographer should look for a gestational sac outside of the endometrial cavity. Another extremely rare pregnancy is the cervical pregnancy. The ultrasound appearance is a barrel-shaped cervix with an empty endometrial cavity. There is the absence of the sliding sign or the inability to separate the pregnancy from the surrounding tissue using the transvaginal probe. Ovarian ectopics present similarly to ovarian germ cell tumours and can be difficult to distinguish. Serology and ultrasound aid in their differentiation. OEPs exhibit the classic cyst-like structure with thick-walled echogenic outer ring, hyperechoic to the corpus luteum cyst. Again, there is a negative sliding sign. Using Doppler ultrasound to differentiate them has little value, as both the CLC and OEP show increased vascularity and the ring of fire sign. A scar from a previous caesarean section may leave a microscopic tract where a blastocyst can implant. It is diagnosed by the absence of the intrauterine pregnancy within the endometrial cavity and the presence of a gestational sac in the inferior anterior myometrium in the region of the C-section scar. The sliding sign is again absent. An intrauterine pregnancy almost always excludes EP diagnosis, although we must maintain caution for the possibility of an EP, especially in the symptomatic woman or when assistive reproductive technologies have been used for conception. Spontaneously arising heterotopic pregnancies cannot be excluded and must be investigated.
Treatments for ectopic pregnancies include surgical and non-surgical options. Surgical options include salpingectomy or salpingostomy. A salpingostomy involves removing the gestational sac through a small incision in the fallopian tube wall. This option is more ideal for patients who may want future pregnancies and is also a less invasive procedure. A salpingectomy is the complete removal of the fallopian tube in which the gestational sac is located. This option is necessary if the gestational sac is located inside the fallopian tube and measures greater than 5 centimetres, or if the previous history shows repeated ectopic pregnancies located in the same fallopian tube. Both surgical options have a similar risk of recurrent ectopic pregnancy, which is 16 to 17% of the treated patients. A non-surgical option is available for selected patients who have blood levels of HCG under 5,000 IU per litre and no fetal heart activity can be picked up on ultrasound. This treatment involves the administration of a single or multiple doses of methotrexate, which halts embryo growth. Ultrasounds only need to be repeated post-treatment if symptoms persist. If an ultrasound is performed post-treatment, the ectopic pregnancy remnant will still be visible for up to 2 months and may appear enlarged due to hemorrhage and edema occurring from treatment. Some patients may also be monitored and managed rather than intervening with medical treatment. This option is only appropriate when the HCG and progesterone blood levels are low and decreasing and the location of the gestational sac cannot be determined on ultrasound. The patient must be closely monitored in case of fallopian tube rupture until their HCG levels drop to under 15 IU per litre, after which point the majority of ectopic pregnancies resolve without intervention. Various pathologies and normal structures may also appear to represent an ectopic pregnancy on ultrasound. If the differentiation between an ectopic pregnancy and intrauterine pregnancy cannot be clearly seen on ultrasound, it is important to further refer the patient, as an indefinite diagnosis of ectopic pregnancy can lead to the void of wanted intrauterine pregnancies. A corpus luteum may have a similar ultrasound appearance, but can be differentiated by its location in the ovaries, as most ectopic pregnancies occur extraovarian in the fallopian tubes. When pelvic inflammatory disease occurs unilaterally, ultrasound usually cannot definitively differentiate between this disease and ectopic pregnancy due to the similarity in appearance. A paraovarian cyst may also be mistaken for an ectopic pregnancy due to a cystic structure, although can be distinguished by having no internal echoes and avascularity in a thin wall. Some dermoid cysts and ovarian neoplasms can also appear similar to an ectopic pregnancy due to their mixed internal echogenicity.
Loops in the bowel may also be mistaken as an ectopic pregnancy by appearing as a mass with vascularity present in the walls. In conclusion, ultrasound plays an important role in early detection of ectopic pregnancy and its location, which is extremely important in order to maintain low maternal mortality rates and distinguish it from other pathologies.